Okay, everyone, I'm really excited about this conversation. We've had terrific conversations for the last 3 days, but I'm really excited about this one. I'm going to bring onto the stage in a second someone I think of as a bona fide global health influencer. Dr. Geeta Nayyar is a globally recognized chief medical officer, technologist, and best-selling author. She helps leaders leverage a human approach to innovation, including rapid advances in AI, to achieve better health and business outcomes. So please welcome Dr. Geeta Nayyar. Geeta, I'm really keen to have you help us navigate through some of the hype and the reality of new technologies to help train health practitioners. We've heard a lot about this the last 3 days, and how technology can also help boost trust in the healthcare system, especially in this age of misinformation, which you wrote a whole book about. I'm going to come on to that. But first, what I want to do, I want to start by having you unpack what you think it's going to take to support the next generation of health professionals, both to create a global healthcare system that puts the needs of patients and healthcare professionals at its heart. So let me start with that. Based on your experience at the intersection of business, medicine, and tech, what do you see as the big picture changes that we need to create this future global health workforce?
Well, first of all, Rajesh, thank you so much for having me. Thank you to the Saudi Commission for Healthcare Specialties, to DevEx, to Kristen, wherever you all are. I'm thrilled to be here with you all. Gosh, so big picture, what's the answer, right? So I think the answer is the same as the problem, right? Which is the problem we all in this room, I think, understand, is that we have so many artificial barriers that are holding the healthcare workforce back, right? One of the reasons I went into medicine, one of the reasons I love STEM, is because it's universal and it's global, right? 2 + 2 is 4, no matter where you are. Checking your pulse is checking your pulse wherever you are in the world. And too often what's happened with the global workforce is that we have these artificial barriers around credentialing, around training, around process. And it's not that the science is different. It's not that checking your pulse on this side of the equator is different than the other side, but it's these artificial barriers that are ultimately holding the workforce back and limiting our access, right? And so the solution is the same, which is how do we actually make the workforce more portable, more translatable, find a way to have standards, but also to universally create credentialing. So whether I'm a doctor in the US, whether I go to Asia, whether I go to Africa, it's the same. And the truth is, it is the same. So it's such a conundrum, because I think for those of us who are in the profession as a doctor, to me, it's so obvious. It's so obvious.
With the lack of interoperability, let's use that word, between even states in the US as well. Tell us a little bit about that.
100%. So during the pandemic, I was the chief medical officer of Salesforce. While I was brought in on the health tech side, when the pandemic hit, very quickly the question was, who's that bleepity bleep Dr. G? Get her bleepity bleep over here, right? So we were in a crisis. I very quickly switched to a human resources hat because we had a problem. And the problem went from a crisis in Brazil to a crisis in Asia, to a crisis in Europe. Wherever our employees were, we had a crisis. And the crisis was going like this. And I was looking at the map and going a little bit crazy, right? And what I realized is that a lot of it had to do with the workforce, but even domestically, as a physician who still sees patients just a little bit, I practice in Miami, I live in South Florida, I have a Florida medical license. And for friends, for family, for people who wanted help in North Carolina, in California, in New York, I could not help them in the past, right?
Because you weren't licensed to practice in those other states.
I was only licensed to practice in my state. So even domestically, we realized as a country that to address the issues during the pandemic, most of which at the time was a workforce issue, we actually relaxed licensure laws. So all of a sudden, having a Florida medical license meant I actually could take care of you in New York and California. And then this great thing called telemedicine happened. So then we started to innovate and started to use technology. You all understand this. You guys are Zooming more than you ever did before the pandemic, right? That's just how we practice now. Telemedicine just became medicine. And the licensure thing, which was largely artificial, completely went away. To this day, this is now the standard of medicine. But very similar to the global workforce issue, we have them regionally. And domestically, I think it's such a great example of when you look at the borderless asset, which is our healthcare workers, how do we make it easier for them? But even more importantly, how do we make it better from a population health perspective and for patients that are so desperate to find a doctor, so desperate to find a nurse, and a qualified one, right? And a qualified one, because we're living in an age where everyone's a doctor, right? Just go on TikTok, you'll find 20, you'll find 50. So we've got to get the narrative back.
Do you know why the original rule was in place that you could only practice in Florida? What is the thing that stops medical professionals from being able to practice in other states?
Sure. So largely legal, right? And largely competition. It's financial, right? Florida doctors want to own the Florida patients, and we don't want to compete. Why should we have to compete with people halfway across the country, right? And what we realize, what I think we're all realizing, and I think why we're here, is there's enough work, there's enough patients for everyone. You can do good healthcare work and you can get compensated for it. So it's really created an artificial competition when we know there's a shortage, there's no dearth. I mean, there's frankly no dearth at this moment of patients to see.
I want to get you thinking at the global level, but this example I think is really demonstrative for us. Now, once those rules were relaxed during the pandemic between states, did the issues go away of legal issues and the competition, or what happened to how were those issues overcome?
Sure. So again, it's not like I never had friends in California asking for medications, asking for a prescription, right? But in the past, I could have gotten sued for that. So what happened when the regulations got relaxed is that the threat of liability went away as well, right? So now it became legal and justified that if I had seen the patient, they were eligible for said medication, then it was perfectly reasonable for Dr. Nayyar, who's based in Florida, to write a prescription for someone who's not in my state. Before that, it wasn't the case. So it's a combination of the compensation as well as the liability and possible exposure that you have to legal ramifications.
So in a healthcare system as fragmented and complicated as the one in the US, if those issues could be resolved during the pandemic, admittedly during the pandemic, what do you see as the key opportunities, but also the key challenges for the global healthcare system if we want to see doctors, nurses, health workers as portable asset?
Sure. So it's the same, and again, we learned that during the pandemic, but Rajesh, today, I mean, you can make a telemedicine appointment, correct?
Yeah.
They've stayed. So here's the thing. I mean, the reason, again, that we're here, we have to start. This starts in the room today. We have to think of the global healthcare workforce as a portable asset. What does that mean? What does that look like? That means standards around credentialing, standards around licensure, standards around training, right? Standards around training. I come from a family of doctors. My mom is a doctor. My dad is a doctor. My mom was an ophthalmologist in India, then went to the UK, did OBGYN, then came to the States and did internal medicine. She did 3 residencies. Wow. That was a waste of time. It was a lot of patients that could have been seen, right? So even in my own family, there were so many hurdles for doctors that were FMGs, foreign medical grads. And guess where the opportunity, the reason they came to America is because there was a rural healthcare shortage. I was born in Beckley, West Virginia, fun fact, right? So rural America could not get American doctors to practice in certain parts of the country. So they brought foreign medical grads, but they made them train again. They made them train again. There is no reason in modern day society that should be the case, right? There should be a standard. There should be a standard exam. There should be a standard way to demonstrate your competence that is universally and globally acceptable, and that then fills the shortage so that there's better healthcare for everyone, better experience both for the doctors and better experience for the patients. Because you know what most doctors do when they have to switch countries and do training several times? They don't do it.
Right.
They don't actually stay in medicine. They actually leave the field, which contributes to the shortage issue and the access issue.
Yeah, so that was, we talked about the brain drain earlier. That's people leaving countries, and then the brain waste as well, which is what you're talking about now. People who are trained professionals leaving the industry or being underused because the opportunities aren't there. And then, let's also think back to the time of the pandemic. That was a time of global emergency. It's one of the reasons, perhaps, that the rules were relaxed within the US. But what impact could better movement of healthcare workers and more standardized training and credentialing have on the world's ability to respond to the next pandemic? It's almost a rhetorical question. I'm not an expert and I could answer this myself, but I want your view on this.
Sure. So the biggest vaccine to the next pandemic is our global workforce, right? We've literally lived through it. The best way for us to prepare for the next crisis is to do exactly what we've been talking about here for the past few days, which is to say it affects all of us. We have a problem. What do we do in our country? What do you do in your country? And where can we find an alignment, right? Because here's the thing, when you have a crisis, you don't have time to think. You don't have time to think. And viruses and bacteria, they don't worry about borders. They're not worried about borders. So why are we treating our workforce like that, right? And what we saw during the pandemic, what we see today, is we move slow. We move slower than a crisis. We move slower than a virus. And so making the workforce portable and agile and being able to surge a workforce up or down during a crisis is critical. And we saw it time and time again, whether it was intensivists, whether it was just basic triage. There's only so much technology can do, but the workforce is our biggest asset in every country in healthcare.
Let's move on to the area of AI and technology. And, we've talked a lot these last 3 days about the opportunity that AI presents in making a workforce that's globally mobile and training as well. I want you to inject maybe a little element of reality into that. There are rapid advances with the adoption of AI, but what do we need to be mindful of? And what is the hype versus the reality in your view?
Sure. So as a doctor and a technologist, I'm gonna level set with the audience, right? So anyone heard any of the hype out there about AI? Right? Have you guys heard that AI is going to save humanity? All of humanity? We're not even going to need doctors and nurses anymore. Have you guys heard that? Right? And then there's the AI is going to be the end of humanity. It is going to end civilization as we know it. Right? The hype seems to be two extremes. Right? And then the reality, and I'm going to bring you into this, Rajesh, you ready? So I don't know if you've been to your doctor's office anytime recently, but anytime, even in the past year, when you walk into a doctor's office, what do you see on the desk? What do you see behind the nurse's station? Are you seeing invisible AI robots? Or are you seeing perhaps a good old-fashioned fax machine? Right? So for those of you that can't, that was a unanimous yes from Rajesh, who's just letting me go free here. So in the United States, one of the countries that spends the most money on healthcare, that leads in innovation, that's doing way more in AI than the average health system, literally the entire healthcare system is being kept together by the fax machine. And you have to ask yourself, why and what will AI do with that? And it goes back to the reason that we're here, and it has to do with antiquated processes, concerns about liability and competition. Because we have something called an electronic health record. We went digital. We went digital in the States in the early 2000s. But guess what happens? I'm Dr. G, and my computer is not the same computer as Dr. S down the street. Why? Because we don't share data. We compete, we belong to different health systems, right? And so the fax machine has really been the intermediary for patients because we might share the same patient, right? I'm a rheumatologist, perhaps they have to see a cardiologist across the street. And patients say it all the time. When I ask, why are you here? And they say, well, my doctor sent me to you because I need a rheumatologist. And I ask why? And they say, well, there was something funny on some of my lab work. And I say, great, what's the lab work? What's the number? And they say, can't you look in your computer? Can't you see? And my answer is, no, I actually can't, right? Not because my computer can't handle it, but because our processes don't allow us to share. And so what we do is we fax the results, because it doesn't matter what system you have or what system I have, they don't talk, they don't communicate, we don't allow the tech pipes to do that. And we have a lag. We have a lag in getting that data, or we repeat the data, we waste money, we waste the time of the patient who's now getting the diagnosis later. And so I share all of that to say, when we talk about the promise of AI, the promise of AI is largely dependent on data, right? AI is only as smart as the data that we give it. And if already in our existing system, we know that there are blind spots on the data, we have to be really honest about what AI can solve for us and what it can't. Because it will not solve our bad behaviors. It will not solve the fact that we don't have universal credentialing, the fact that our workforce is not portable, right? These are not technology problems, these are process problems. And AI is terrific at repetitive tasks. It doesn't need to rest. It's not good at judgment. What is your workforce really good at? Judgment, empathy, right? And why do patients come to the doctor, come to the nurse? Because they want someone to listen to them and they want someone to trust. AI can only be a helpful clinical decision support tool to the workforce, to augment the workforce, right? And I'm all for that. Maybe I normally see 5 patients an hour. With an AI tool, perhaps I could see 10, perhaps I could see 15. But make no mistake, my patients come to see me. They are not coming to see an AI chatbot. They are not coming to see an AI version of me. The patient knows the difference. And so we have to remember that fundamentally, we are in the business of humanity. We are in a human services business. And while there are many tasks AI can take on, frontline care belongs with frontline workers. And back-end care has any number of possibilities as we think about things we can do with AI, but only if we use it responsibly, only if we understand what is clean and what is not clean about the data. And frankly, we're still learning. We're still learning a lot about AI and what it can do, what it can't do, what it hallucinates about, what it dreams about. So we have to keep a human in the loop when we are talking about a human services industry like healthcare.
I can tell why, when you described yourself first as a clinician and then as a technologist, because you're not putting the technology ahead of the people, which is different than a conversation we had on this very stage just a couple of hours ago. Stefan Wiesbauer, who's sitting in that chair, who's an ed tech entrepreneur, was talking about how young patients are quite happy talking to an AI instead of a human doctor. They find it more empathetic. But I think the point you're making is that a lot of other patients, and that's especially as the population ages, they don't want to see a robot.
So here's the thing. So a couple of points. And man, we should have done that panel together. Maybe next time, right? So what I would say is, first of all, young patients are typically healthy. When they come to the healthcare system, it's usually what I would call a transactional visit. They need birth control, they need a prescription, they need an antibiotic. It's typically a one-time, easy solution. When patients who are 65 years and older have hypertension, diabetes, COPD, they're coming to the doctor's office frequently. And they are seeing not just one doctor, but often many. right? And they are interacting with the healthcare system in a chronic and repeatable fashion. And it gets complicated, right? And if they have to start over each and every time with a new doctor, a new nurse, we have all these workforce shortages, it becomes an issue, right? And it's very different than actually having a relationship. And we know this because of studies. When we have continuity of care, when we see the same patient over time, it's a relationship. It's very simple.
But that's the reason to have AI, isn't it? Because AI is not going to forget.
Well, AI is going to help you with the data piece, right? And it's going to help you hopefully pick an even better treatment plan and the most up-to-date treatment plan and make the diagnosis. But AI is not going to say, you know, Mrs. Jones, I see that you haven't taken your medications in 6 months. Is that because it's too expensive? Is that because of transportation? Is that because your son lost his job and he's usually the person I see you come with? AI is not going to pick up on the people stuff. And guess what? That's where healthcare always falls down. That's where healthcare falls down. And so it's complicated, right? And that's why I think the human in the loop, using AI to make the workforce stretch, is the correct place to put it. But technologists, perhaps like the gentleman, I don't want to speak for the panel before, technologists are very focused on replacing the workforce. When you ask technologists about AI in healthcare, they get very excited. And they say, well, we don't have enough doctors, we don't have enough nurses, we'll just replace them. AI is going to replace them anyway, right? That's their answer. And the truth is it's a lot more complicated because I don't know about you, Rajesh, but I don't want AI anything delivering my baby, delivering my grandbaby, doing a surgery for someone in my family, right? There is a role, there is a place. And I will also tell you that medicine is full of innovation. I mean, CT scanners, MRIs, Da Vinci robot. We love technology, right? When it helps us do what we were supposed to do in the first place, which is take care of patients. It can't just be because we can build it, we're going to build it.
I have to say, my childbearing years are behind me now. It's actually a shame that you were not on...
Thank you for sharing. Thank you for sharing. Bold.
It's actually a shame that you were not on that panel. I think that would have been a really fiery panel. But it's great to get a different perspective. That's just what we have the space to do in these 3 days, I think.
Well, and I want to add one more example, right? So we have a lot of technology in healthcare and medicine in the States, and I know you come from the UK, you have the NHS, right? In the States, we went from paper to digital in the early 2000s, and it was all the rage that we were going to have electronic health records, we were doing digital transformation, and here's what happened, very similar to the way we're talking about AI. And here's what happened. It actually got in the way of patient care. It actually slowed down the doctors and nurses because it was built so focused on from a technology perspective and not enough from a patient care perspective. This is what happened in the States. Okay, Rajesh, this is what happened. You came in and I said, okay, you got back pain? Is that a 3 out of 10? Was that when you sit? Was that when you walk? One, we stopped talking to our patients. We stopped looking them in the eye. We started to just become data entry clerks typing on a keyboard, right? Two, we did solve several problems with the technology, but we created about 5 new problems for the workforce. And now instead of seeing 5 patients or 6 patients an hour, I actually saw 3. And then I had to go home and get back on the computer and do all kinds of paperwork that never existed before that innovation was even in place. And so my argument with AI is it's way more powerful than a lot of the innovations in hospital systems today. But we need to be thoughtful, and we need to bring the workforce with us, right? When we talk about those global standards, what worked for you? Can you share your best practices with us? Because we're at a different stage, right? How do we actually even determine best practices for AI that will make the workforce smarter, better, and faster at the bedside versus we thought it would, and it actually didn't, so don't even bother doing it in your country, right? Very important because we've done it before and we kind of screwed it up. We screwed it up big time.
Oh, I love this dose of reality. Thank you. It's really, really refreshing. I want to get onto this issue of misinformation, but I just want to stay on one thing that occurred to me while you were talking. You talked about, it's a waste of time if someone from another country has to come to, say, the US and do another residency, right? You talked about different types of doctors don't share data. And that's duplicative, and it's a waste of time as well, and money for the patient. Both of those are revenue models for the physicians and for the medical school. So if we're going to try and build the partnerships that we need to be able to support the evolution of the health workforce into a global asset, a portable global asset, what needs to happen? What are the partnerships? What's the reassuring? What are the alternatives that need to be built so that medical schools is like, yeah, that makes sense, actually, yeah.
100%. So, healthcare is a team sport. It always has been, right? And it's a global team sport. That's why we're all here, right? So, number one, governments need to lean in, decide on the frameworks, right? This is the one exam everyone has to pass, or this is the one standard everyone must complete, right? There needs to be a unilateral, kind of universal standard that everyone comes to grip with, right? And I think that needs to be led by government, right? Number two, training. Right? Medical schools, what is it in training? And increasingly, that is going to include digital literacy, right? It is going to include clinical skills, but it's also going to include trust skills. It's going to include AI and what that means and how do you use it at the bedside correctly, incorrectly, how to know when it's right, how to know when it's wrong, right? What are consumers reading and doing? And then lastly, and I think this is where everyone in the room comes in as well, the private sector, right? The innovation, the platforms, perhaps the gentleman that was on the last panel, keep innovating, keep provoking us, keep innovating and coming up with things we've never had in healthcare, but maybe we have in the banking industry. Maybe we have in other industries like retail that are so much further and so much more innovative than healthcare. So I think it's really that trifecta of government, medical school training, and then the private sector that's innovating constantly and giving us more platforms and more opportunities to push what we can do with the human workforce.
Interesting. Audience, in a second, I'm going to come to you for anyone who's got any questions for Dr. Geeta. So start thinking. I know people don't often like to go first, so don't be afraid. So start thinking about what you might want to ask her. We have some time for questions. Before we do, though, let's talk about misinformation. You wrote a whole book about this called Dead Wrong. What role do you see for healthcare workers when it comes to rebuilding trust in health systems in this age of misinformation?
So, mis and disinformation is not new in healthcare, right? All of us in healthcare have always known that I describe it as the beige, boring wallpaper in the hospital, right? Not anything like this. This is gorgeous, right? But something we kind of always knew was around. Somebody's grandmother told you this, the neighbor told you that. If you're from India, it's ginger and turmeric. Don't worry about antibiotics, right? Somebody always said something.
That's true, though. That one's
It is true. That is true. That's right. Plus antibiotics. But anyways. So it's always been around, but now that we are in this era of AI, now that we are in this era of consumerism, do-it-yourself everything, Dr. TikTok, I mean, you name it, right? The wallpaper is now neon pink, and mis and disinformation is actually spreading 6 times faster than the facts. And the healthcare workforce, the healthcare institutions, payers, providers, hospitals, we have not been able to keep up because we have felt like we're so busy saving lives. We're too busy saving lives. We don't have time to solve that problem. And that's largely why we've gotten here, because we have been silent. We've not focused on the problem. We've not thought about how to communicate. We've not thought about how real doctors should be on TikTok and how hospitals should support that and payers should reimburse us for that, right? And so part of what we have to understand about this global workforce issue is that the global workforce is the last anchor of trust. And if we don't start talking about science and facts and putting some cool dance moves to it, right? Somebody else is selling something else to your patients and mine. And it's largely because it's accessible, it's easy to understand, and they trust them more than us because we abdicated the trust from the get-go when we said we're just going to ignore it. It's somebody else's problem. And so I think part of this new workforce is the opposite, which is to say, how do we keep the trust? How do we embrace these technologies? How do we make that part of our job, get compensated for it? But why can't I be the doctor on TikTok, right? Rather than this entertainer who is selling a supplement or selling a subscription, it should be our workforce that is so empowered and so loud and so good at communicating and using these tools that patients would never go anywhere else.
Just backstage, you were talking about, in this country again, there are direct examples of that, of hospitals not allowing their doctors to be on social, or to do it kind of at arm's length from the hospital. Talk a little bit about that.
So again, processes, right? So in the U.S., for the most part, when a hospital finds out that their doctors are on social media, they usually get singled out. They get a conversation from the legal team, from the compliance team, from the safety team, and they are directed to not mention the hospital. They are advised to have a disclaimer that this is not medical advice, right? And largely, it's absolutely not encouraged. It's almost shameful that you would be advertising of sorts rather than empowering the workforce, rather than saying, you are my workforce. You see patients, you are credentialed at my hospital. You've gone through the processes. You've done the residency, the license. You're absolutely, empowered not just to talk to patients in our facility, but also when you go home, because this is what you do at our facility. And on top of that, how can we pay you? How can you lead a committee? How can you inspire other doctors on the staff to own the conversation? I was really encouraged recently. Kaiser Permanente started a TikTok channel with their staff. And they basically put the whole thing together, and they have real doctors on TikTok saying, hey, this is what, I'm a GI doctor, and this is why I think you should get a colonoscopy. And if you have a question, come make an appointment. So I think there is a business model that works in today's environment, but it's the processes, and it's the liability, and it's the shift in culture and mindset. You just talked about younger patients being okay with AI. Let me tell you, absolutely the next generation of patients is going to first be on every channel. And if the hospital doesn't have that channel, they're not tuning in, and they're not going to make an appointment.
This is the issue that a lot of legacy media companies and established political parties have faced. They're not where the audience is. All right, talking about where the audience is, let's see if anybody does have any questions for Dr. Geeta. We have a few more minutes. Again, don't be shy. I know it's coming to the end of the day, and we are between you and refreshments. But let's see if anybody has any questions. I can't see it. Oh, there we go. There we go. Lady in the center. Thank you. There's a microphone for you.
Hello, this is quite wonderful and illuminating and compelling and inspiring. So I'd like to thank you and our sponsors, our global sponsors. My question to you is, in terms of AI, there's been a lot of research indicating confabulation and errors. So in terms of assuring nascent, newly developed AI diagnostics, would you suggest we have global councils that agree, that would be comprised of MDs in many countries and PhDs in many countries that are part of the regulatory boards? I think it could be quite interesting, but I'd be very interested in your perspective.
Thank you. Well, first, I didn't catch your name.
Oh, I'm Susan Krause. I'm the president and founder of Green Corsair Labs Global.
Wonderful. Well, thank you, Susan, for your question. Yes, very simply, yes, and. So I think that's one part of the solution, but largely there are so many factors, I think, that are still evolving around AI, right? And I think that it's very important that we crawl, walk, and run, because this is a technology that is fascinating, and I think is completely going to change the name of the game, not just for the healthcare industry, but for so many industries. And so we really have to be thoughtful about where and when we use it and what standards we use, but it's moving so fast. It's moving so fast. And so to think of how that is going to play out in different parts of the world is itself going to be very fascinating to see, right? In the United States, particularly in healthcare, there's a fine line between regulation and innovation. I mean, I just gave you an example of telemedicine. It's not because I couldn't phone in a prescription in California that I didn't do it. It was the regulation that prevented that, right? And so different regulatory environments are going to accelerate the pathways of how we adopt these things. And so I think there's a lot to be learned. The more we can share best practices, the more we can come up with what are those standards, it's going to be critical. But I think it's going to move so fast that it will be almost impossible to come up with what that standard is anytime soon, anytime soon.
Thanks for the question, Susan. Is there another one from our audience? Oh, yes, go ahead, sir. And if you could start by telling us your name and your affiliation.
Thank you very much. I'm David Halpin from the UK. I sit on the board of the global COPD guidelines, the GOLD group. So we develop international guidelines on COPD management based on the literature.
You're the person that Susan was talking about, basically.
Yeah. But I think there's a real challenge with AI. So we've got AI creating just a chatbot type opinion, but AI is being extensively used now to create scientific literature, and create both in the sense of Dominic writing it and publishing it, but also fabricating it. So I could go to ChatGPT and say, write me a paper on how bananas solve mental health problems. And it will generate a very compelling data set and a manuscript that would get accepted. And for those of us that are in a position of judging that, it's almost impossible to judge what is genuine, real science with people and patients and experiments from what is pure fabrication and what's halfway between the two. I did a study, it didn't quite show what I wanted, so I'll tweak the data, I'll create false images that give me the answers I want. So I don't know what your thoughts are on AI and the generation of the sort of background science rather than the delivery.
I mean, it's a fantastic question. I would certainly read a paper on bananas and mental health. I think that sounds fascinating.
Seems intuitive.
Correct, absolutely. And so maybe in that is an opportunity, right? Because we do see AI being used to check AI, right? And then there's obviously all kinds of ethical ramifications, professional licensure, professional kind of policing that happens every day in the healthcare world. So I think it's going to be much more than just AI, but that in itself is an entire study and an entire regulatory piece, right? But then there's also just professional ethics. People have always cheated. People have always done things they shouldn't. And we have always had to police that. And so how do we do that? And what tools do we have to do that? I think are just as big of an opportunity as how we use this technology to solve.
So the self-declaration is, you're asked now when you submit a paper, did you use AI in its generation? And most people say no. And it's very hard to detect, but there's some interesting linguistic differences between stuff that's written by AI and stuff that's written by humans. And if you analyze abstracts on, say, PubMed, in 2024, there was a nice study, I think, in JAMA, showing that something like 30% of the abstracts on PubMed, when you analyze them linguistically, had been generated by AI or had AI as part of the contribution to it. And 99.9% of them, the authors would not have admitted to using AI in the generation. So I think there is a huge professional credibility issue. And when publish or perish is the challenge, a lot of junior fellows are wanting to churn out material. Your future depends on it, your grants depend on it, your income depends on it. There's a huge incentive to fabricate or to tweak data in ways that really we're not capable of detecting.
I mean, the entire educational system has the same problem, right? The average college student writing a paper. I'd hate to be that teacher, right? This is a problem. This is a huge problem. We will have to sort it, but I will not pretend to have the answer for you. But it is a problem, and not just in this industry. And perhaps that's another question, is how are we working across other industries? Because it's not just unique to healthcare. This is a problem across the board.
Yeah. So listen, we have very little time left. I want to get one closing thought from you. What suggestion do you have for our audience, for our hosts, as they drive the future of healthcare transformation and bridge the gap for the global healthcare workforce?
You bet. The first thing I would say is, despite all the problems we've talked about today and in the past few days, we've talked a lot about solutions, right? You are arguably living at the most exciting time to be a healthcare leader on the planet. You have lived through a pandemic. You have AI at your fingertips for good, bad, or otherwise, right? People that were in your seats 10, 20 years ago were not nearly as full of the opportunities that are in front of you. So I would first say, be bold, meet the moment, connect with the folks in this room. The answers to all these problems are in this room. I believe that we fundamentally have to work together to solve these global health problems because they are very universal. And healthcare is the most universal industry that there is, right? 2 + 2 is 4. And it doesn't matter who you are, it doesn't matter where you come from, it doesn't matter how much money you have, we all have a healthcare story, and most of them don't end very well. And so there's a common thread that we all have and a common passion to solve for it. My other point would be to think globally, connect globally, but to remember to act locally, right? The last anchors of trust is the global workforce. And being in your communities, knowing your communities is critical to being successful globally. And lastly, meeting the moment, right? Meeting the moment, having more solutions, being optimistic about problems, and just thinking outside the box, right? Thinking outside the box, but the biggest asset we have in healthcare remains our workforce, and ensuring that it is borderless is really the biggest opportunity in front of you. I am one of your biggest fans. I wish you all the success, and I'm just thrilled to have been part of the conversation the past few days.
Everyone, please help me thanking Dr. Geeta Nayyar.